All right, hello everyone. We're going to be going over the material covered for our Complex Health 1 exam. Complex Health is a cumulative course, so I did want to include the information that was on your previous exam to hopefully maybe clear up a few things, give you a refresher. That way you guys can go back and you can watch this, etc. So let's begin. We're going to start out talking about our respiratory disorders. Now, keep in mind, in this course, we're going to go over chronic diseases. People have had these diseases for a while. So our main focus as nurses right now is going to be about our medication management, how we're going to educate our patients, what we're looking for, do we need to run any labs, how would we do an assessment on these patients? Assessments are really important. So just keep all of those concepts in the back of your head while you're studying to really focus your note-taking efforts there. So the first disease we're going to talk about is tuberculosis. Tuberculosis can really be categorized into two subgroups. We have our active TB versus our latent TB. So as nurses, we need to understand, what does our patient currently have? If my patient is currently experiencing active tuberculosis, we need to protect ourselves. We're going to be put on airborne precautions. These patients will be a bit more symptomatic. They're going to have that productive cough, hemoptysis, and most importantly, they're going to have episodes of diaphoresis at night when they're trying to sleep. So in order to diagnose, we really need a chest X-ray. And then we're also going to try to get a smear from their mouth. When my patient is in latent TB, they are not capable of spreading the disease. So unfortunately with tuberculosis, most patients that have active TB will eventually become stabilized, but that TB is still going to stay within their system. It's going to remain dormant. And usually it exacerbates when the individual is under stress, specifically when the immune system weakens. Why? Because we know the stress response in the body is going to put us at risk for infection. On an X-ray, you'll actually see small calcified granulomas that kind of look like coin-like lesions, etc. So we really are concerned that this is highly communicable. So us as nurses, we need to protect ourselves. So review what it would be to put a patient on airborne precautions. Unfortunately, risk factors, you have your immunocompromised, crowded areas, our low socioeconomic status, and ER nurses specifically, because we might not know if a patient has TB or not. So what are we going to do? We're going to want to get a quick test. We're going to get a sputum culture, and then we're going to get a chest X-ray. So I would just review kind of some lab values, what we're going to check, specifically review your PPD test and go over that. So what are we going to do? We're going to put our patient on our RIPE drugs. So what is that? That's our rifampin, isoniazid, pyrazide, ethambutol. Now, these patients are going to have to be taking this medication for a long time, about 3 to 6 months. So as nurses, we really need to stress the importance of our medication compliance. We really want 90% adherence most of the time. Why? Because we don't want to develop a multi-drug resistant strand. So what are we going to do? We're going to put the patient in an isolation room, airborne precaution, and support them. In order for our patient to be diagnosed as like free of active tuberculosis, they need 3 negative sputum cultures. Our drugs, our medications are going to get us there. So we're also going to, let's say our patient was living with their family, we're going to teach the family that you are already living with this patient. There's no need to isolate at this point in time. And really, we need to stress the importance of not drinking or consuming any alcohol because of how toxic it can be on the body and it can be on the liver. So to aid your studying efforts, I would go back to your pharmacology notes because we did cover these drugs in pharmacology class. So how are we going to educate our patient if they're taking rifampin, isoniazid, pyrazamine, ethambutol. What are they looking for? Some of those meds might cause some orange secretion, so we want to educate our patient on that so they're not calling us, freaking out. They're not showing back up in the ER saying, I'm crying and it's orange. So please, please, please review your medication, your medical treatment for this disease process. So now we're going to talk about COPD. So COPD is, again, a chronic disease combination of chronic bronchitis and emphysema. Not going to spend too much time going over the pathophysiology, but just really know the number one cause for this is smoking. So what are we going to do? Educate all of our patients on smoking cessation, which we'll talk about at the end of this lecture. So with this issue, not only is our bronchial tree inflamed and it's just irritated, we also have hyperinflation of the lungs. So these patients really are going to have a hard time respirating. They are not going to be getting adequate oxygenation, and so we're just really concerned about this. So these patients are going to be at risk for infection. Why? Because they have really big mucus plugs gathering up in their lungs that they can't really cough out as forcefully. We're really concerned for hypoxia and hypercapnia. Really concerned for respiratory acidosis. The respiratory acidosis comes from that hypercapnia, the buildup of carbon dioxide in the blood. We're also concerned for severe polycythemia to compensate for our lack of oxygen. So we're not getting enough oxygen. These patients usually sat at around 88 to 92. So what's the body going to do to compensate? It's going to generate more red blood cells to try to carry more oxygen. But they're not necessarily going to carry more oxygen. They're just going to be there ready to accept if the patient does get some extra oxygen. So our hematocrit, hemoglobin and hematocrit is going to increase. So again, what's our risk factors? Smoking, asthma. There's a little bit of a genetic component as well. Me as a nurse, what am I looking for in these patients? Well, we have to prioritize our plan of care. So a lot of these signs and symptoms are from chronic COPD. So if we are kind of ranking them on what is our priority assessment, we follow our airway, breathing, circulation. So airway, number one, we need to look, what are their O2 sats? Are they satting well? With these patients, usually they sat between 88 and 92, but if I start dipping below 88, I really need to give them some oxygen. But I have to keep that oxygen within that nice sweet spot, that nice range. All of these other symptoms that prolong expiratory phase, the digital clubbing, barrel chest, hyperinflation of the lungs, those are all complications of chronic COPD. So if I'm assessing my patient and I see the clubbing, the barrel chest, hyperinflation of the lungs, I'm not necessarily concerned for an exacerbation, but I am concerned that this patient does have COPD and can have some negative complications associated with that. I'm also concerned for cor pulmonale, which is our right-sided heart failure from our respiratory disease. So keep that in mind too. We want to also include maybe listening to our patient's heart. Is there any adventitious sounds, etc.? Because I really don't want right-sided heart failure. So these patients usually are going to have that respiratory acidosis. Why? Because they have a difficult time breathing out the CO2. So CO2 just keeps building up in their body. And we know it's a respiratory problem because we can link it to the carbon dioxide causing the acidosis. And just review your x-ray. So what are we going to do? These patients are going to be on an array of respiratory medications. So we're going to have them on their albuterol and the salmeterol. Review, what do we give our patient first? If they are experiencing an issue, are we going to give them their rescue inhaler first, or are we going to give them their salmeterol next? Well, we always want to give them the rescue inhaler first. Why? That's going to actually open up the airway. So whatever meds we have to give them after, they can actually get in, if that makes sense. We're going to give them their tiotropium, their Spiriva. So review kind of why we're giving that, how we give that, etc. And then our beclomethasone, what does that do? It's just going to relax the airways, promote dilation. We're also going to give them corticosteroids to dilate the airway, decrease inflammation, etc. Mucolytics, those are going to help with those mucus secretions that put the patient at risk for infection, etc. Lung volume reduction surgery is not done very common, but if it is, we really want to make sure we understand those post-op considerations, making sure our patient uses their incentive spirometer, chest physiotherapy, that they're up and moving, etc. So as nurses, we want to get a CBC and sputum culture. Why? These patients are at risk for increased respiratory infections. So we're going to want to do that. We also follow our ABCs, airway, breathing, circulation. We want to maintain oxygenation stats between 88 and 92. Why? These patients are used to not getting adequate oxygenation because this is a chronic disease. So the body adapts, the body's amazing. It eventually just gets used to it. Yeah, they're going to have that digital clubbing, etc., but they're still relatively all right. So if our patient dips below 88, we're going to put them on a nasal cannula. But we're going to continue to monitor that patient, especially the level of consciousness and mental status. Why? If my patient's oxygen stats get above 92, they may be at 96, 98, 100, they're going to have major issues with their mental status. They might be having delirium, they might be confused, agitated, whatever, because we've just hyperoxygenated our patient and their body's freaking out because it's just not used to having that much. So monitor their level of consciousness when we're giving them their oxygen. So what are we going to do? Educate. High protein, high calorie diet. These patients waste so much calories just trying to breathe that we are concerned that they're going to become malnourished. If my patient's having an exacerbation, we can teach them to either do our pursed lip breathing or our diaphragmatic breathing. The pursed lip breathing, that's in through the nose and blowing out through a straw. In diaphragmatic breathing, you can encourage them to lie down, place a book on their belly, and by breathing through the diaphragm, they want to see that book go up and down. And of course, number one, smoking cessation. Provide them with the resources for that, which we will go over. So our obstructive sleep apnea, this is, again, another chronic issue, really linked to obesity, people with short necks, if they have like larger mouth structures, smoking, etc. So essentially what happens is during sleep, the muscles of the tongue and neck relax. What does this cause? This causes our soft palate to become displaced and obstruct our airway. So this causes a rapid drop in pH, hypoxemia, and hypercapnia. When this occurs, the patient wakes up, they take that nice big breath in and out, breathe a few times, and then go back to sleep. This cessation of breathing usually only lasts about 10 seconds, but it happens pretty frequently. So what are our chronic complications? Risk for hypertension and stroke, cardiovascular disease, weight gain, etc. But think about it. This patient is waking up 5 times an hour every night. Their sleep schedule is not going to be very good. So we're really concerned for the risk of narcolepsy with these patients. So keep that in mind too when we're giving certain medications. What's our number one concern? That they're going to fall asleep at the wheel driving, that they're going to fall asleep doing something, and they're further going to injure themselves. So what do we look for? Snoring is number one. Usually a spouse or a partner, roommate kind of lets us know because these patients might not know that they're snoring. Also, they're just going to feel chronic lethargy. They're going to wake up tired. They're going to be aggravated, irritated. Think about it. If you went months not sleeping well, how would you feel? So some things we can use to kind of diagnose is our Stop Bang Sleep Apnea questionnaire. What's used more often is our overnight sleep study. And ultimately, we're going to refer them to ENT to determine the course of action. So how am I going to treat this? Well, number one, what was our concern? Our concern was safety with the narcolepsy issue. So we're going to give them modafinil. All this does is promotes daytime wakefulness. So we can kind of reduce the risk of our patient falling asleep on the job, falling asleep at the wheel, hurting themselves, etc. These patients can also receive oxygenation at that time. Most commonly, the patient is going to be put on a CPAP machine. This is just because it's the most affordable and it gives a patient that constant airflow, but I did include some other different oxygenation masks, things like that the patient can wear at bed. So again, we're following that issue for safety. We don't want to give our patient any sort of medications that could sedate them. Why? Well, think about it. These patients wake themselves up when they're struggling to breathe because their body is still alert. Their body knows what's going on. So the body knows I'm building up pH. I'm not breathing. Let me wake myself up and breathe. But if we sedate these patients, they're not going to be able to wake themselves up to breathe when their soft palate starts to close off their airway. So we never want to give these patients any sort of sedation medications. If they need to be sedated, they're most likely going to be intubated as well. We don't want to give them food before bed. Why? Risk for choking. And if we have these patients, monitor their O2 sats. And again, we want to educate them on not using alcohol, CNS depressants, sedating drugs, etc. So let's talk about allergies. This is a little bit lengthy, but I'll try to breeze through it. Basically, allergies is just a hypersensitivity reaction to an antigen. There's multiple different types of hypersensitivity reactions. Just keep in mind how a person can get allergies. They can be inhaled, ingested, injected, etc. For our purposes, we're going to talk about inhaled allergens. But essentially, the body creates an overactive immune response. What happens with that? Massive inflammation. So with our allergies, we are concerned that if there's any inflammation in the throat, it's going to close off the airway. So I included a little bit of information just on the basic patho of your allergens for your convenience. So what are we concerned about? Well, we're concerned about our anaphylaxis. With our anaphylaxis, we are concerned about hypotension. Why? We're not breathing, the body is swelling, all of our blood kind of just starts to pool in places, so we're concerned about hypotension. So if you notice your patient who's kind of coming in, short of breath, wheezing, etc., we want to monitor their blood pressure. Again, angioedema, facial swelling. If we swell a lot in the face, again, we're concerned about airway obstruction. And then hives are another one. So what are we going to do? Administer epinephrine in this emergency situation. There's also different types of treatment, but treatment's going to be supportive, symptom management. So you can give them montelukast, diphenhydramine, nasal congestion sprays. With this, make sure to educate your patient that you don't want to use these very often. If we start using them regularly, when the patient stops, they can have a rebound effect. So now all of a sudden they've been taking their nasal spray for weeks and they stop using it, and now they just keep having a runny nose, etc. Also teach them avoid nasal washes. These really don't help in these situations. We can also give them bronchodilators. There's possible allergy shots, some CAM, complementary and alternative medication, vitamin C and zinc, etc. We can also encourage our patient to chart their exposures and allergies in a diary. Why? So that they can avoid these allergens. So asthma. Asthma kind of goes a little bit in detail with allergies. So what is asthma? It's a hyperresponsiveness to a trigger. I included all of these triggers, so make sure to review those. But essentially, the upper airway swells. And in this kind of overactive immune inflammatory response, histamine is going to cause that swelling and increased production. So what are we concerned about? Our airway gets smaller and smaller, it gets clogged, and now my patient cannot breathe as well. So this is going to interfere with airflow and gas exchange. Again, there's a really high genetic component with asthma, but also smoking, secondhand smoke, really puts the patient at risk. So signs and symptoms upon auscultation, your patient might have a wheeze when they exhale. You're going to be able to assess them. They're going to be using accessory muscles. They're going to have a hard time breathing, etc. So some short-term signs and symptoms, they're going to have hypoxemia, cyanosis. Why? Think inadequate oxygenation. Whereas if our patient kind of has long-term asthma, they might start to develop that barreled chest. And how is it diagnosed? Our pulmonary function test. So again, review how we do pulmonary function tests with these patients. So what are we concerned about? Again, we're concerned about a respiratory acidosis. And we're also a little bit concerned about respiratory alkalosis too, but any sort of pH issue there. So what is status asthmaticus? Basically, it's a severe asthma attack that results in respiratory failure. What are we going to do? Give them their SABA, their short-acting beta agonist. How we're going to monitor our patient's progression, etc., or if they need their SABA, is with our peak expiratory flow rate. Basically, this patient blows into the PEFR, and depending on if it's a red, yellow, or green zone, this is going to let us know what med they need. So I also included some medications. So just kind of review some medications we would give them, but always give them their SABA first. So in an emergency, we follow our ABCs. We want to give them the oxygen therapy. We want to administer meds, frequently assess them. Don't just give them their SABA and walk away. Stay with the patient, and then teach them always carry your rescue inhaler. So now let's talk a little bit about neurological disorders. So up first, we have our Parkinson's disease. I included this picture. I really do like it. I think it kind of brings the whole disease together. Specifically, if you have your notes and are following along, I would highlight that mask-like blank expression, stooped posture, pin-rolling tremors, bradykinesia. They have that weird arm swing. They don't have a normal arm swing, the rigidity, etc. And then their shuffle, the Parkinson shuffle. So what happens? We really don't know what the cause of Parkinson's disease is. All we know that it's a degenerative disease causing a decrease in dopamine production. So what's the function of dopamine? Dopamine helps send messages to the brain to control our movement and coordination. But there's also kind of an inverse thing happening as well. As we decrease the dopamine production, we end up having an increase in acetylcholine. Acetylcholine helps with neuron firing with our muscles. So what does this mean? Well, how are we going to treat them? If we know we have too little dopamine and too much acetylcholine, our treatment is going to be based on increasing our dopamine and decreasing our acetylcholine. So again, I included these signs and symptoms, these hallmark signs and symptoms of Parkinson's. Really kind of pay attention to those cogwheel movements, the shuffling, the mask-like expression, etc. And unfortunately, the only way to diagnose this is post-mortem. When we do an autopsy, we'll actually see Lewy bodies on the brain. So what do we give these patients? Drug of choice is our Sinemet, our levodopa carbidopa. It allows the medication to last longer. Again, in pathophysiology, we kind of reviewed that the carbidopa helps the levodopa kind of ride up and cross the BBB, the blood-brain barrier. So just review that. But just be careful. It can also cause dyskinesia. So just review that. We also want to give them anticholinergics to help block acetylcholine. That's what the function of anticholinergics are. So drug of choice is really going to be our benztropine, our Congentin. This is going to help with our tremors, but review, what effects do our anticholinergic medications have? They dry you up. So providing that education of, okay, drink extra water to help with the constipation, increase fluid fiber fruits, etc. So review that. We also have our COMT inhibitors to help with the to help stop our body from breaking down that levodopa. So for this one, I would remember your side effects is that it can have dark urine and the patient has to avoid tyrosine foods. What are our tyrosine foods? Anything that we find on that charcuterie board, those aged meats and cheeses, wine, etc. There's also an antiviral med that can be administered, amantadine. This really, again, is going to help with our dopamine levels. So what are we concerned about with these patients? Again, when you're asking yourself this, airway, breathing, circulation. Let's start with airway. we really want to get a respiratory consult to do a swallow study. Why? These patients have difficulty swallowing. They drool a lot. We went back to our symptoms. What am I concerned about? That they're going to not be able to swallow. So with these patients, we might need to help them brush their teeth. We might need to suction, etc. These patients are on fall risk, so really keeping them safe. And then always having your suction at bedside, keeping the head of bed elevated. Why? I think our priority nursing diagnosis is going to be this risk for aspiration. And so keep that head of the bed elevated. So what are we going to teach our patient? Take these medications in the morning. These medications are going to help the patient be a little bit more mobile, a little bit more functional during the day. So we want to teach them to take it in the morning, but also allow times for rest. Again, back to our aspiration pneumonia, chin tuck swallowing. When they're eating, make sure they tuck their chin in to help them with their swallow. Really promoting a safe environment is super important. Why? These patients have a little bit of a difficult time moving around. So maybe we don't want extension cords all over the place. We don't want their house to be decorated and adorned with rugs. Are there pets in the house? How can we keep our patients safe? So kind of going along the lines of movement and mobility, let's teach them that when they stand up, they might have difficulty. So as they're sitting on the side of the bed, have them rock a few times. If you're in the hospital, you can actually do this with them, but just kind of helping them rock to gain momentum to get them up. And then to help with the freezing gait, instruct them to march. So Huntington's disease. This is an autosomal dominant disease, meaning the chances of a child inheriting this disease is very common. So this kind of poses an ethical dilemma on the parents when they're trying to have children, because unfortunately, this disease process doesn't have a very good outcome. And so it can be very challenging for parents when they're kind of working together about this issue. So just really know with our autosomal dominant, 50% chance of passing it down to a child. Is that kind of a risk these new parents want to take? So what's happening? This is, again, autosomal dominant genetic disease. Essentially, our body's having a difficult time managing our GABA, glutamate, dopamine. This causes way too much dopamine. On the last slide, we viewed what our function of dopamine is. So as you can see, this is going to have a lot of movement issues. So this dopamine is going to cause these chorea, the chorea movements we'll talk about later. Again, the body just has a hard time making mind to muscle connection. So usually death is due to issues of immobility and respiratory issue. We already talked about the number one risk for immobility is pneumonia. That's why when you're on your clinical floor, you have PT always working with these patients. We want to get them up to chair every 2 hours. Why? If they're laying in the bed all the time and not moving, risk for pneumonia. So unfortunately, once signs and symptoms start to develop, there's about a steady decline for about 15 years until the patient unfortunately passes away. A little side note on juvenile Huntington's disease. This usually happens earlier in life. The signs and symptoms just present before they're 18 years old, where usually in Huntington's, they kind of show up at around, 30 years old. So our first signs and symptoms are going to be our changes in mood, personality. Then you're going to start to see these chorea movements, limbs, trunk, face. Unfortunately, these patients are now going to have progressive dementia. They're not going to be able to reason, walk, speak, etc. So a lot's going on. Again, difficulty swallowing, difficulty making that mind to muscle connection of I am taking in this food, I need to swallow it. That's going to be a big one. So as we talked about with Alzheimer's, how do we keep these patients safe? Same thing. And then unfortunately, muscle wasting and weakness. Really diagnosed with genetic testing. So what are we going to do? Treatment is supportive. Unfortunately, there's no cure, but we're going to try to improve quality of life. So we're going to give them tetrabenazine. This is just to help with those chorea movements. And it really also protects the neuron from damage. We can also give them antipsychotic medications to help with the extrapyramidal movements, which we talk a lot about in pharmacology class. So again, number one, airway, breathing, circulation. I'm concerned for airway, aspiration pneumonia. So what am I going to do? I'm going to do all those interventions we talked about in the last few slides. With these patients, they can still understand, but they may lose the ability to reason and talk. So kind of educating them early on. What is the end of life care you wish to receive? Would you like to be DNR? Just all those things like that. So really early planning is very important in getting the family involved if it's per the patient's wishes. Again, high calorie, high protein, easy to digest foods, and encourage family testing. All right, multiple sclerosis. So multiple sclerosis, kind of unlike the other two diseases, multiple sclerosis actually, the patient can pretty much live a healthy life. They're just going to have some signs and symptoms that might be a little bit difficult, but this really doesn't impact really their lifespan, if you will. So again, I included some pretty hallmark signs and symptoms for MS. So let's begin. Again, another autoimmune inflammatory response. This one attacks the brain and spinal cord, specifically our myelin sheaths. What do the myelin sheaths help? They help with sending nerve impulses. So again, back to that mind to muscle connection, our body has a hard time with that. It doesn't affect our lifespan. Really, the issues are going to be our cognitive and sensory issues. There's multiple different types of multiple sclerosis in your pre-class worksheet. It kind of went over some graphs of different types of multiple sclerosis, so you can review those. But I would just know once an exacerbation occurs, no matter what type of MS the patient has, they're not going to be able to go back to baseline. Why? During that exacerbation, that body really, really attacks those myelin sheaths really heavily. So when the exacerbation is done, unfortunately, the damage is also done. So just know they might not go back to their baseline function. They usually won't. So some signs and symptoms, this myelin sheath destruction causes muscle spasms, but it causes muscle spasms everywhere. So just keep that in mind. So they're going to have issues with hyperreflexia, fatigue, pain, specifically with our eyes. This disease likes to target the eye a lot. They might have diplopia and sarcomas, blind patches. So really getting ophthalmology involved is going to be important. Also, our UTOF sign is pretty important. This is worsening of vision after exertion. So let's say my patient was at a rec league playing volleyball and all of a sudden had really, really bad blurry vision. Well, we know that in MS, usually they're going to have this worsening of vision upon exertion. So just placing your education there. They're going to have a difficult time with decreased perception, specifically like maybe they have a hard time picking up their cup, or they might not be able to feel and perceive when they need to go to the bathroom. So just kind of keeping all of those in your mind. Rare and serious cases can progress to tetraplegia. They might be wheelchair bound, so keep that in mind too. With our MRI and our CT, they do show plaques. If we do a spinal tap, lumbar puncture, it's actually going to show an increased amount of proteins and immunoglobulins, specifically IgG, in our CSF. So just kind of keep that in mind. That's another way we can diagnose. So what are we going to give these patients? Well, this is an immune response. So we're going to probably put them on immunosuppressants, corticosteroids, dexamethasone specifically. Immunomodulators, these also help. Just keep in mind that when we're giving our patient their immunomodulators, they might have flu-like signs and symptoms. So they might have that runny nose, etc. You can give them dalfampridine to help with walking because these patients might struggle. Again, mind to muscle connection, left foot in front of right foot. This medication is going to help with that. And then unfortunately, muscle relaxers, because why? We talked about that hyperreflexia. They might be very tense. That's not good. So we're going to give them muscle relaxers. So I included all these different types of muscle relaxers. Specifically, baclofen is pretty commonly used with these patients. But with these muscle relaxers, we can't abruptly stop taking. So again, what is our goal of any sort of type of treatment? Limit exacerbations to preserve function. Once damage is done, it's done. So what do? Consult speech language pathology and occupational therapy. These patients might need a little bit of help doing their ADLs. Again, a big one for these is preventing UTIs. We talked about their issues with perception. They might not know when they need to go. So we want to teach them to maintain a voiding schedule. If they can't tell when they need to pee on their own, okay, let's make sure you're going to the bathroom frequently just to try. There's different types of things we can do. In hospital, we can place catheters. The Krebs maneuver, where we kind of push on their lower belly, will help too. Again, monitoring their swallowing, speech, and vision, etc. So with these patients, they're relatively manageable, but just think about all of our ADLs. They just might need a little bit of help. But always give them time, support, etc. So what is our goal for these patients? They're going to be on immunosuppressants. So what do we need to do? Teach them how to stay safe. This disease also is characterized by exacerbations and revisions. So how do we limit exacerbations? Avoid stress, triggers, smoking, sun, and extreme temperature changes. We don't want these patients taking baths, warm, hot baths. We don't want them, running and sprinting outside in the Florida heat when it's 100 degrees. So just kind of helping with that. And we talked about all of the visual issues. So eye patches can also help with these patients. So, Lou Gehrig's disease. Lou Gehrig's disease is a little bit different from the rest of the disease process we talked about. Because with the other disease process, there is kind of like a cognitive component where there's a little bit of a cognitive decline with these patients. Whereas in Lou Gehrig's disease, it strictly affects the body. So all of this is happening to these patients, but they are completely aware. So we can only imagine that they're going to have a lot of psychosocial issues. They're going to have anxiety, high risk of depression, suicidal thoughts, because unfortunately they know and they're kind of a witness to everything that's happening with their body. So keep that in mind. I know we haven't necessarily talked about, getting psychiatric help, but for this one, keep that in mind, why these patients know everything that's happening to them. So what is happening to them? Let's talk about it. Fortunately, really, again, we don't know the cause, but we do know that it targets the central nervous system in the brain. It really destroys the upper and motor neurons over time. So eventually the brain and body just can't communicate anymore. So it starts out with that loss of muscle control, eventually progresses to muscle weakness, and eventually progresses to complete paralysis. So think about with these patients, these loss of control, weakness, paralysis, it starts outward and it eventually goes inward. So these patients might start presenting with, issues with their feet, walking, etc. They might have like changes in their face, twitching, etc. But eventually this paralysis just creeps up, and unfortunately death is due to that respiratory paralysis. And the death is usually within 3 to 5 years. So signs and symptoms, muscle atrophy, weakness, kind of everywhere. Fasciculations are a big one. They're going to have twitching of the face and tongue. This progressive muscle weakness is followed by spasticity and hyperactive reflexes. So keep that in mind. And just knowing that really a lot of it's just progressive muscle weakness and paralysis. So for this, there's no definitive test. They need a full history, neuro exam, etc., and then lab tests to pretty much rule out everything else. There's still a lot more research that needs to be done with ALS. Fortunately, there is no cure. Our goal of care is really going to be focused on symptom management and assisting with ADLs. We really need a team approach and around-the-clock care. As this disease progresses, these patients won't be able to bathe themselves, care for themselves, brush their teeth, move. So we're really going to we're going to grab a whole entire team together to care for these patients. 2 medications we can use. We can give them their riluzole. This helps to slow the progression, but it won't stop the progression. We can also give them their edaravone. This helps just reduce oxidative stress because we don't want to further damage those neurons. So nursing interventions, ABCs, aspiration precautions, of course. These patients won't be able to eat, so we have to make sure we initiate these enteral feeds and maintain adequate nutrition. And then, like I talked about earlier, monitor for anxiety and depression. It's a big one with these patients. Unfortunately, this terminal disease really can take a toll on patients and their family. Usually this happens, 30s, 40s, when they have kids, a wife, husband, anything. So just kind of keeping that in mind. So what do we want to do upon early diagnosis? Really discuss this end-of-life care in an advance directive. So migraines. Basically, a lot going on with our migraines. Just know there's some brain tissue inflammation giving a patient these headaches. These headaches can last a pretty long amount of time, really anywhere between 1 to 2 days. These signs and symptoms, though, photophobia, nausea, vomiting, pulsating pain, those are kind of consistent with all of our migraines. So I included basically the 3 different types of migraines. A patient can have a classic migraine, which includes an aura. There's also migraine without an aura. These are our common migraines. So just kind of reviewing what differentiates both. And then at the bottom, I included our atypical migraines, which really we can't classify. So there's 3 different types there. So let's focus on more of our treatment for these. Really, we want to avoid triggers. Usually migraines can be brought on by stress, etc., but it's tailored to the patient. So each patient will have their different triggers. So just keeping that in mind. We can also use opioids and beta blockers to help. There's a lot of different CAM methods, herbal remedies, Botox, yoga, etc. But really, we're going to focus on some pain management. So we're going to do abortive therapies. We have to use these during the aura phase or before the start of symptoms. So we can give them NSAIDs, and we can also give them sumatriptan, which helps abort an ongoing migraine. So if our patient comes to us with a migraine, well, what are we going to do? First of all, we know the photophobia, the loud noises aggravate them, loud night, etc. We want to decrease stimulation. So put them in a cool, quiet room, ice pack on the forehead to help. And really, we just want to leave them alone as best we can. You can frequently if you're going to do your care, kind of cluster your care so you're not going in and out and in and out. You do want to assess them for safety. But really, for these patients know they have these migraines. They just want to be left alone. Elevating the head of the bed also helps, pain meds, etc. However, we are a little bit concerned if our patient is over the age of 50 and they now start having a new onset of migraine symptoms because we're thinking that this might be something else. So just getting that as well and advocating for your patients. So our education really is going to be based around avoiding triggers, how to prevent migraines. So get a good night's sleep, stay hydrated, etc. So our SLE, our systemic lupus erythematous. Again, I really enjoy these photos. They really help a lot. I think putting everything together. Big one with these is like our photosensitivity is a big one, butterfly rash, etc. So let's talk. Again, another one of our chronic progressive immune disease. Basically, our anti-nuclear antibodies just cause immune complexes to deposit in tissues in the body. So what happens, these immune complexes kind of drop off in places, and our body's immune response will then attack these immune complexes, and it's just a recipe for disaster. So it causes inflammation and progressive loss of tissue integrity. Now, keep in mind, this is an autoimmune inflammatory disorder. This affects the whole body. So wherever these immune complexes deposit, our body attacks. They can deposit anywhere. really they like to deposit in our organs, so can lead to organ failure. So what are our complications? Well, our body has massive inflammation everywhere. So we're concerned about kidney damage, kidney nephritis. What if these complexes damage in the heart, pericarditis, lungs, pleural effusion, muscles, myositis, polyarthritis, vasculitis? It's just not good. So our hallmark signs and symptoms with these patients are going to have that butterfly rash above the nose and cheeks that we did talk about earlier. Raynaud's phenomenon is a big one, so review what that is and the patho behind that. Painful and swollen joints. They might have alopecia, changes in mental status, etc. To talk about the risk factors a little bit, this more commonly occurs in women. And I kind of included what causes our exacerbation, because we know this is an autoimmune disorder. So possible issues of exacerbation is going to be our triggers, our infection, injury, drugs, hormones, UV light, estrogen. I'd highlight our UV radiation, sunlight makes this disease a lot worse for these patients. So how do we test if our patient has this? Again, they're going to have that positive ANA test. We can also assess them for inflammatory markers. Our ESR and our CRP are big ones. These patients will have pancytopenia, decrease in white blood cells. They're also going to have an increased number of lupus cells and inflammatory cells. And that's really how we're going to diagnose them with lupus, because just inflammatory markers aren't enough. Any patient can, if there's any sort of inflammation, our patient can have those markers. So what are we going to do to treat? Number one, we can give them NSAIDs if they are in a lot of pain. However, exercise caution. We know that these patients are at significant increase for kidney damage and nephritis, which then puts them at risk for chronic kidney disease. So really, if our patient is showing any signs and symptoms of decreased kidney function, we're not going to want to give them these NSAIDs. So that's just a little caveat. Also, corticosteroids, specifically prednisone, is really going to help with that inflammation. Again, immune disorder, we give them immunosuppressants. Why? Our body's immune system is causing all these signs and symptoms, so we need to suppress our immune system. We need to tell our immune system to calm down. So really for these, really teaching your patient to have these done. Specifically with methotrexate, we are really tanking our body's immune system with this drug, so they can't receive any sort of live vaccine. So providing education for that is super important. Also, it can kind of have some visual side effects, so maintain frequent eye exams. We can also give them hydroxychloroquine for their rheumatoid arthritis. Plasmapheresis isn't used as common, but essentially what this does is it just kind of takes the patient's plasma and we give them new immunoglobulins to kind of help, ones that might not cause that overactive immune response. So really our nursing interventions, again, chronic disease for this one, really is going to focus on assessing for complications. Think about inflammation everywhere, inflammation in the organs. So I'm really concerned for chronic kidney disease and cardiovascular impairment. So again, monitoring those patients' signs and symptoms of heart failure. They might have decreased urinary output. They might have difficulties, they might have increased BUN, creatinine, et cetera. So assess for that. And then frequent skin assessments for these patients, especially having them do skin checks, body checks, et cetera. So what are we going to do? Teach the patient to report a fever over 100 degrees. Why? This is because of our risk for infection. We are on immunosuppressants. We are concerned. We also know that infection can also trigger an exacerbation. Again, not good. If our patient is experiencing an exacerbation, encourage them to rest, stay hydrated, eat food, etc. Skin protection is a big one. Avoid UV. There's certain creams and lotion for these rashes. We just really want to make sure we're not drying out their skin. For the alopecia, a mild protein shampoo can help as well. And again, avoiding ill individuals, they're on immunosuppressants. This includes kids, toddlers, family members that are sick, avoiding, the hospital if it's not necessary. So just kind of keep all of those in mind. So last but not least, we're going to talk about smoking cessation. Smoking cessation is very important as we begin to talk about our cardiovascular disease. And as we have already talked about our respiratory disease, smoking cessation is super important in preventing long-term complications, long-term chronic diseases. Smoking is really the number one risk factor for a lot of our respiratory and heart disease. So it's not just enough to teach your patient, you need to stop, you need to stop, you need to stop. I guarantee you, every family member, every doctor, everyone has told these patients, you need to stop smoking. So what do us as nurses we need to do? We need to help connect our patient with resources to make it accessible and easy for them to begin kind of their journey, their recovery to smoking addiction. So I always start with the health risks. All forms of tobacco, smokeless, dip, chew, all of it is associated with severe health risks. So teach them the benefits. We're going to reduce your incidence of coronary artery disease, prevent more damage to your lungs. Cancer is a major, smoke is a major carcinogen. Tobacco is a major carcinogen. But really focus on the lungs and the heart. Something that can kind of help us assess our patient's history is by calculating pack years. It's also going to be important when we start to talk about medications, because if my patient has a really high pack year, they might need a little bit more help and resources in stopping because they're going to have an increased risk of withdrawals. It's going to be a little bit harder for them to stop because they're used to having so much. It also kind of helps us assess possible damage, possible health complications, etc. So I always start with just asking the patient if they're ready to stop. We can use a really good resource for them. It's called Time to Quit. So what happens with this is they choose a start date. They just choose a date to stop, and then they get support. We'll talk about support in a little bit. But I did include on this slide some ways to stay successful in recovery. So, of course, avoiding triggers, remove ashtrays from the house, minimize your time around smokers, create your why list. Why am I going to stop? And it's going to be tailored to the individual. Maybe the patient has a wife and children, and they want to, be able to play with their kids, etc. Asking for help is a big one. It is incredibly hard to do this alone. There's plenty of support groups, Facebook pages, etc., dedicated to helping with this. Drinking plenty of water is also going to help. They kind of have a constant need to kind of just take something and put it in their mouth. So really drinking plenty of water is good. We want to expect weight gain with this. Why? Because we know that smoking kind of makes the patient less hungry. So a lot of times when we stop smoking, we're going to kind of regain those hunger cues that we might have been missing. But we don't want our patient substituting it with potato chips, etc. So teach them that weight gain is anticipated, but let's help mitigate the negative health outcomes associated with weight gain or eating unhealthy foods. So incorporating exercising and having healthy snacks, carrot sticks to snack on, etc. And then participate in activities that keep your hands busy. They are so used to always having their pack and putting it in their mouth. So maybe drawing, painting, doing an adult coloring book, knitting, sewing, anything to keep their hands and their mind busy. So finally, a big helpful piece of smoking cessation is our nicotine replacement therapy. So if we're going to educate our patient to stop smoking, we need to give them resources. NRT is a big one. It's very effective. It helps them, but we need to make sure that they are not smoking. If a patient is on NRT and begins smoking, they are at an insane risk for seizures. So what are some ways that we can help our patient? In the hospital, we see this very frequently. I just saw this 2 days ago when I had clinical on Thursday. These patches, my patient specifically had a 14 milligram patch. But the dosage varies depending on how much they smoke, how bad the withdrawals are, etc. So these patches can be used for 4 to 6 weeks, and the dosage really does vary. Side effect for these is vivid dreams. With these nicotine patches, though, we really want to make sure that we are charting when and where we've placed a patch, because if we go to put on another patch, we need to make sure the other patch was removed. So just keep that in mind. There's also lozenges that these patients can use. Similar to cough drops, we suck on these, but we don't want to swallow them. Why? Because the effect they're going to get is from sucking on them. For gum can be used for 3 to 6 months. Teach these patients how to use the gum. It's not like regular gum where you just chew and chew and chew and chew and chew. They chew till they feel a tingle, and then they're going to park it in their cheek. With this, make sure that they're not drinking coffee, juice, or tea before chewing. It can kind of mess with the effects. Inhalers and nasal sprays aren't really recommended. They are an option, so I left them there for you guys, but not really recommended in the clinical setting. There's also their varenicline, their Chantix. This helps with withdrawals. And eventually this dose does get tapered. So they might start, let's say, with 0.5 milligrams a day for 3 days. And then that might go to 0.5 milligram bi-daily. Then it might jump up to 1 milligram bi-daily, or sorry, 0.1 milligrams bi-daily for 12 weeks. So this dose does eventually taper to really help combat these withdrawals and these cravings. With this, teach your patient it must be taken with a full glass of water, and letting them know some of the side effects, specifically like our impaired judgment is a big one. And finally, bupropion. This is classified as our antidepressant. Again, there's a lot of contraindications with this disease. And as we talk about psychiatric medications in in pharmacology class, it will get a little bit easier, but just know that this has major contraindications. So think about any sort of neuro issue, contraindicated. Seizures, bipolar, head trauma, bulimia, alcoholism, etc. And then again, our side effects include dry mouth and sleeping. So that is all I have for you guys for exam 1. I hope this was informative and this kind of helped a little bit. But really, when it comes to being a nurse, if you will, we always want to assess our patients first. That's our number 1. We also want to kind of follow our hierarchy of needs. Safety and security is at the top, number 1. So really making sure they have that airway, breathing, circulation, our patient is safe, and doing our frequent assessments. If I know my patient has a history of SLE, what do I want to incorporate in my nursing assessment that's going to give me clues to if an exacerbation is happening or is the treatment working, etc. A big thing is going to be patient education. These are chronic diseases, meaning the patient is going to have to live with them. So they need to be properly educated so that they can best care for themselves. We can care for them as well as we can in the clinical setting, but really once we send the patient off, it's up to them. So really focusing on your nursing considerations and your patient education is a big one. When it comes to the medications, specific disease process, like our MS, they have specific medications. So really understanding why that medication is being used and what I need to further educate my patient on, or if I'm a nurse giving this medication, what do I want to focus my attention on? So just keep those in the back of your mind. Again, those are just kind of how I help kind of gather your nursing focus, gather your notes, gather all of that kind of around really making a care plan for your patient. Again, resources for practice questions, specifically the NGN style questions are going to be very important. Those help as well. But yeah, I hope this was a really good broad overview for you guys, and kind of helped a little bit, give you a little bit of a refresher and help. But if you guys need anything, please just let me know.